All right, welcome everyone. Thank you so much for joining us today. My name's Bree. I'm the Health Promotion Coordinator for Arthritis Queensland. And before we start, I'd just like to mention that this presentation contains general information and advice. So the content is not a substitute for the individual treatment advice of your doctor or health professional. So always consult with your doctor or specialist to obtain individual medical or treatment advice. And in the spirit of reconciliation, Arthritis Queensland and New South Wales acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to the elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. Okay, so this webinar is about biologics and biosimilars for inflammatory arthritis. And I'm really excited to introduce our special guest speaker joining us today. So Helen is the Executive Director of Translation at the Translational Research Institute. She is an experienced rheumatologist who divides her time between clinical practice at the Princess Alexandra Hospital and her role driving collaborations across research and healthcare. She is an Associate Professor with the University of Queensland and a previous NHMRC Translating Research into Practice Fellow. Helen has experience across the research spectrum, including basic science, clinical trials, and applying the principles of implementation science to a clinical field. Helen is a non-executive director and is currently on the board of Metro South Hospital and Health Service, and previously Arthritis Queensland's chair and the Princess Alexandra Research Foundation. So I'll now pass it over to you, Helen.
Good afternoon. Thank you, Bree. Hopefully everybody can hear me well and can see me. That was a lovely introduction. Thank you, Bree. Completely unnecessary. Suffice to say, I'm a rheumatologist, and today what we're going to do is talk about biologic medications, and we call them BDMARDs. And we're going to restrict today's talk to inflammatory arthritis. So just to give you a bit of a flavour of today, this is what we'll try and cover. So we'll talk about biologic DMARDs, so disease-modifying agents. That's really the term that we use now, BDMARDs, in inflammatory arthritis. And broadly speaking, inflammatory arthritis can be caused by lots of different diseases, but today we'll restrict our discussions to rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis, bearing in mind that there are lots of conditions that can cause an inflammatory arthritis. So we'll talk about these diseases and we'll talk about what causes them, because our greater understanding of these diseases, right down to the immune system level, has what's enabled us to really start to use all of these somewhat newer medications, although these medications started to become available in Australia in the early 2000s, so 2003. So we have had these medicines for the best part of 20 years now. But a number of them have been added over the last couple of years. So we'll talk about these targeted therapies, and we'll talk about a little bit about how they fit into the treatment of inflammatory arthritis, because of course they're not the only treatment. And then we'll talk a little bit so that people understand the difference between biosimilars, conventional DMARDs, targeted synthetic DMARDs. There's a few different names that we call all of these different blocks of medicines now. And as Bree mentioned, I'm really happy to take some questions, but please feel free to put them in the chat as you think of them, but I'll address all of the questions at the end. So let's start with rheumatoid arthritis, because it is the most common inflammatory arthritis across the world, actually. So the prevalence of about 2%, which probably means at the moment there's about 500,000 Australians who have rheumatoid arthritis and are living with this disease. It is very disabling. There are statistics that are really concerning that even with all of these treatments that we're going to talk today, perhaps even as many as 1 out of 5 people are really finding it difficult to work even after 5 years of diagnosis. And so the personal health costs related to rheumatoid arthritis are very high. Rheumatoid arthritis is a condition that is systemic. So what we mean by systemic is the whole body is involved, with the primary sort of outcome being this inflammatory arthritis. So don't get too scared by this screen. I wanted to just talk a little bit about what we understand in rheumatoid arthritis. Essentially, what we understand now is that people have a genetic predisposition, and then there is an likely environmental factor or trigger that results in the immune system starting to do the wrong thing. Now, that is probably because there's a confusional state via this immune dysregulation. And then there's a period of time, actually, which we understand particularly regarding what we call seropositive rheumatoid arthritis. And that's the sort of rheumatoid arthritis where we can find the autoantibodies in the blood tests. That there's a period of time where there's actually the immune dysfunction has occurred and there's a level of systemic autoimmune change even before people have started to develop their joint symptoms. And that period of time can be variable, but might even be up for some people when we look at blood tests. Perhaps this was even the case for them for a couple of years prior to them developing the symptoms and being diagnosed. And then what we see, of course, is what is most common to rheumatoid arthritis is inflammation in the joints. And this is actually stemming from inflammation of the lining of the joint, which is called the synovium. And the synovial tissue is actually got loads of immune cells in it. And it's actually the understanding of all of these immune cells now, which have led us to be able to block parts of the immune system, which essentially are what the biologic DMARDs are. So I'm going to go through just in a little bit more detail in a little while, but you can see on the right-hand side there that there is not just one singular process in the immune system that is affected or can be targeted here. There's actually a lot of different pathways that are activated. Hence the reason now actually why we have a number of different drugs. So psoriatic arthritis is the type of inflammatory arthritis where the person also has the skin condition psoriasis. Psoriasis is a very common, in fact, it's the most common inflammatory skin disease with, again, a similar prevalence to RA actually of about 1 to 3%, depending on where you might live and your ethnic or other backgrounds. But about a third of people who have the skin condition psoriasis will at some point during their life have that skin condition complicated by the development of an inflammatory arthritis. And that's when we call this psoriatic arthritis. And people can get a very similar inflammatory arthritis to rheumatoid, but it can also be very different. And there are a few differences that help us make the diagnosis. And those differences are that sometimes or often the arthritis is a bit more asymmetrical. So you can see here in this picture, one knee affected and the other not. We tend to get something that we call dactylitis, which is where a whole digit, whether that be a finger or a toe, gets inflamed and can get, sometimes we call it a sausage digit because the whole digit itself becomes inflamed. And we often see a different pattern of inflammation. You can see in this picture here that the inflammation is more in the joints that are further away from the hand. We call these the distal interphalangeal joints, as opposed to rheumatoid, which tends to affect back here in the metacarpophalangeal joints. And with psoriatic arthritis, some people, not everyone, a small percentage might also get trouble in their sacroiliac joints, which are the joints where essentially the pelvis joins onto the spine. We understand also a lot more about psoriatic arthritis now. And this is really important because when we talk about the medicines, there are some medicines that work. Some of these biologic drugs work for psoriatic arthritis, and in fact, they don't work for rheumatoid arthritis and vice versa. And the reason probably is related to the background genetics. And therefore, what we understand from the genetics are there are different pathways that are activated in psoriatic arthritis. Some of them are same, but some of them are different. And the other thing that we know about psoriasis or psoriatic arthritis is that obviously you've got the inflammation in the skin as well. And you tend to get inflammation at what we call the enthesis, which is where the bone and the muscles come together. So, for example, that might be your Achilles tendon as a good example of what an enthesis is. But that's actually also what can occur at lots of bony junctures. Let's just talk about ankylosing spondylitis briefly as well. It's a less prevalent condition. It's more common in men than women, although it occurs in both. And this is a condition that occurs before the people are 40 years old, so in younger people. But bearing in mind, it might be diagnosed later than that for a whole variety of reasons, but the symptoms themselves will be there before the age of 40. And it's where we see an inflammatory back pain. It's associated with this gene called the HLA-B27 gene. And essentially, you get inflammation which affects the spine, which begins in these sacroiliac joints. And over time, you get progressive stiffness of the spine because there is what we call ossification of those little entheses. So there is bony remodeling around the place where those entheses are around the spine, and that's what causes that progressive stiffness. But there are other things that can happen at other places with ankylosing spondylitis. You can also get an inflammatory arthritis, which is a lot like the psoriatic arthritis subtype. And really important to bear in mind here that with ankylosing spondylitis, there can be other conditions associated like psoriasis, but also inflammatory bowel disease and also inflammation in the eye, which we often call uveitis. So again, we understand much more about ankylosing spondylitis than we used to. The genetic I guess, finding over the last 15 years, which has really helped us in this space, is that they found that there was a gene in this cytokine receptor. Cytokines are just parts of the immune system that functionally do things for us, generally to protect us, called the IL-23 receptor. And understanding that that's the case has led to us understanding this full pathway where we can know there's different places for us to block with the particular drugs that have been developed. So this really leads us to start to think about or to talk about inflammatory arthritis management. Now, there are a couple of things to say that are really important here. And that is that if you have inflammatory arthritis, your rheumatologist will tailor your treatment to your specific symptoms and the severity of your particular condition, okay? What I often will say to patients is that we currently don't have any ways of predicting exactly how each individual will do with each treatment. And that is really a very big area of research at the moment, trying to work out the right medicine to give to the right person. But at the moment, some of you might have experienced having to trial several different treatments to find the best one that does work. But as a general rule, the medicines that are used are anti-inflammatory, so simple things like ibuprofen and otherwise, which help with inflammation and symptoms. Progressing to corticosteroids or steroid medications, either as tablets or injections. So that's cortisone injections, or prednisone is generally the drug that we use in Australia. And then there's disease-modifying agents, and that's really what we're going to talk about today. The first And I guess the oldest group of those drugs is what we call conventional DMARDs. And DMARD just means disease-modifying anti-rheumatic drug, an unnecessary acronym, which now we're stuck with, but that is what that stands for. But essentially, they're drugs like methotrexate, leflunomide, hydroxychloroquine, sulfasalazine, and we have used those drugs for many, many years and continue to do so because they are very effective, sometimes by themselves and sometimes in combination. And then, as I mentioned, these newer drugs, which we used to call pretty much universally when they first became available, biologic drugs. And that's because the original ones of them were all of this particular biologic class. And I'll talk about that in a minute. But an example of that is the first ones that came on the market were etanercept and infliximab. And now there's a whole lot more of those. And then in more recent times, we have drugs that we call targeted synthetic DMARDs. And really, that's just a fancy name for the fact that these are what we call small molecule drugs. And the reason that that's important is because they're so small that they can be taken as a tablet. So biologic medicines generally have to be given as an injection because they're large molecules and they can't be taken up by the gut and therefore, go through the system to be used. Whereas small molecule drugs, an example is tofacitinib, and there are others, is small enough to be a tablet. And so that's why there's sort of these three groups. I just really want to emphasize that today's talk is about the medicines, but really it's very important that medicines are only one part of management. And we know for absolute sure that healthy lifestyle choices make a difference for everybody, but particularly in inflammatory arthritis. So that's staying physically active, that's exercising as you can, that's a healthy diet, that's absolutely stopping smoking, reducing stress we know is important, learning about your disease and how you might be able to protect your different joints that might be involved, managing tiredness and fatigue, which we all know can be a very big part of these conditions, managing pain, which can be different for everybody and might require a whole number of different approaches. Seeking support, for the feelings and the difficulties that occur with having diseases such as this. And really considering that a rheumatologist like me, we are just a very, very small part of what might be part of your management plan. And really that centers around medicine, that actually there's a load more people that are more helpful than us, and that's your GP, and that's a physio, and that might be an exercise physiologist, it might be an occupational therapist, might be a psychologist, might be others. But that support from a whole number of different health professionals, your pharmacist is another good example, is really important. So let's just go for some definitions before we talk about things specifically. So sometimes you hear people say a biologic. And a biologic drug, like I said, are those original drugs, and they're just medicines that are actually, by definition, made or extracted from a living organism. And so they are these large molecules that, like I said, they do need to be given intravenously or subcutaneously, so as injections. But they're not just the drugs that we use. Biologics actually include hormones, enzymes, a variety of other things. A biosimilar is a copy of a biologic medicine. So it's different to a generic form of a medicine, but it is because a generic is an exact copy, right? But a biosimilar is, as the name suggests, very, very close. In fact, pretty much bioequivalent to the biologic drug, but they're a copy, okay? And then there's the small molecule medicines, which I've already talked about, and they're basically compounds which you can take as a tablet because they're small enough to pass through and to be utilized. Regardless of the drug, the way these all work are by targeting something we understand to be contributing to the inflammation, right? So they might target different parts of the immune system, but they're all working by generally blocking something that is contributing to the inflammation. So let's talk about that. Let's talk about that in rheumatoid arthritis for starters. So again, don't be too distracted by this picture, but this is a good picture to show you. If you think back to that picture of the joint that I had up before, these are all the pathways, the fancy immunological pathways that we now understand contribute to the development of this inflammation. And we can essentially now block different parts of that for an effect, for a good effect on inflammation. And so the original biologic medicines that became available were these things called anti-TNFs. And we now have on the PBS for rheumatoid arthritis a number of different anti-TNF medicines. Tumor necrosis factor is what the acronym stands for, and it's a cytokine that is pro-inflammatory. So if you block it, and we don't just block it in RA, we block it in lots of different diseases, it will chop off the inflammation. The reason why there's different ones is because they all have different half-lives. So that means that the drug will last for a different length of time. So as an example, etanercept is a weekly medicine. Adalimumab is a fortnightly medicine. Golimumab is a monthly medicine. And that's based on how long they last for. And then we have a drug like infliximab, which has to be given, generally given as an intravenous form, so via a drip coming into the day procedure unit, having a drip. We do have a subcut form of it now, which is used less commonly. And the others are given as subcutaneous injections, meaning a little needle underneath the skin that delivers the medicine. Once we got a few anti-TNFs, there was a lot more research going on and we were understanding other areas. The ones that came on after that and still remain in use are tocilizumab, which is an anti-IL-6 drug. IL-6 is also a pro-inflammatory cytokine, so different to TNF, but nevertheless one that propagates all of this inflammation. We have rituximab, which rather than blocking a cytokine, actually blocks or prevents the production over time of a particular immune cell called a B cell. And so we basically give rituximab as an infusion, and it stops B cells from being produced, which stops this whole section of this inflammation pathway from occurring. We have abatacept, which is a drug that blocks a different one, as the name suggests, called T cells. And T cells are involved again in a whole different part of this immune process that's going on. And then most recently, we have what they call JAK inhibitors, and these are small molecules. They are given as tablets rather than others. And they're actually what we call cell signaling blockers. So they work right at the level of the cell, and they block, if you like, the cells talking to each other. And by blocking those cells talking to each other, it blocks backwards, if you like, where all of these cytokines and things are having their effect. And we have quite a few of those medicines now. Biosimilars started to become available in Australia, I think 5 or 6 years ago, perhaps a little bit earlier. And biosimilars, like I said, they're a copy. The reason biosimilars are important is because they reduce the cost of the original drug, because the drug comes off patent and biosimilars are able to be used. So because these drugs are quite expensive and the government purchases them on our behalf, and then we access them through a particular PBS or Medicare scheme, biosimilar drugs pull down the cost of the originator as they come on the market. There's been good research over time, and we feel very comfortable with the biosimilars now, that they work as effectively. They do not carry any additional side effects or otherwise to the originator, and they can be very easily and seamlessly, at least from a pharmacological point of view, interchanged or substituted for or started instead of for one of the original drugs. I just wanted to mention here, because I wanted to talk about where these drugs fit into being treated. So with rheumatoid arthritis, not everyone will require one of these medicines. In fact, perhaps 30% of people would require these medicines, and many other people can be managed with the conventional medicines very effectively. So that will be methotrexate, hydroxychloroquine, leflunomide, and sulfasalazine. And like I mentioned before, perhaps a combination of those. Because these other medicines should be used as a second line, if you like, the PBS actually requires us to have first tried those medicines. So for rheumatoid arthritis, you have to have had a trial of these medicines for 6 months at certain doses. And then at the end of that 6-month period, you have to have a number of joints that are still active. So that would be tender and swollen as a description. And you have to have inflammation in your blood. And the way we look for that is these two markers. One's called an ESR and one's called a CRP, and they have to be over a certain threshold. So the rheumatologist then has to show Medicare, show the PBS that all of those things are as that the individual patient fulfills those criteria, and then you can apply to the scheme to use one of these other medicines. Now, how do we make a choice about which? And well, this is the most trouble in the clinic, because now I have all of these drugs to use, and that is fantastic, and they work really great. But I don't necessarily know which one to give as a definite one for each individual person. So we will make a choice based on a few things. Is this your first time that you'll be having one of these medicines? Perhaps you've already had one of them, and so we might consider using a different class because the other one hasn't been successful. Do we think you might run into particular side effects with particular drugs? So, for example, we might stay away from tocilizumab if you are known to have diverticular disease, because we know in some people that might increase your risk of running into some trouble. If you, and there are particular things to particular drugs that might make us think you might, that might be contraindicated, as in you can't have it at all, or we just think that your risk of running into trouble with that particular drug is higher than another one, so we choose a different one. Patient choice is really key here, because some people will prefer taking a tablet, some people won't mind a subcutaneous injection, some people will prefer can say, yeah, I'll take an injection, but can I have the one that's once a month, as opposed to one that's once a week? And then infusions can be problematic for people as well, but in some ways they can also be helpful. So rituximab, although you have to have an infusion, 2 infusions 2 weeks apart, you only have to do that every 6 months. And for some people, that is, a good option. So a shared decision is really important in terms of which medicine we might use. Let's just briefly talk about psoriatic arthritis, because it is different, okay? Because there are different drugs that work for psoriatic arthritis. There's some that are the same. And you can see that this picture here shows pretty much all the anti-TNFs are the same, right? TNF is involved virtually in any kind of inflammation that we see in the body. TNF will be there in amounts that are contributing to the inflammation. So if we block it, in all of these conditions, it tends to work. But then you'll see that there's this group of drugs called anti-IL-17 and anti-IL-23, which we do not use in rheumatoid because they don't work. And that's going back to where we understand the genetic differences between these two diseases. And so we have access via the PBS to these anti-IL-17 medications and anti-IL-12 medications for psoriatic arthritis that we don't for rheumatoid. The JAK inhibitors have most recently been shown to also work very well in psoriatic arthritis. So we also use them. The criteria for psoriatic arthritis is different. So it is set at only 3 months of having those conventional drugs. But the joint count and the inflammation in the blood and things needs to be the same. One of the differences with how we might choose the medicines for psoriatic arthritis is really dependent on people's skin. So these drugs work variably for the skin and for the joints. So it might be that somebody has psoriatic arthritis and just has a small amount of psoriasis. And so the drug that we use in that case might be different to somebody whose skin psoriasis is covering their whole body and is awful. And they also have the joints. There's different control with these particular biologics that might cause us to use one over the other. So for example, the anti-IL-17 medicines work more effectively for the skin than the anti-TNF drugs. And so there, we might consider the different medicines based on different things. And just briefly, in ankylosing spondylitis, it is a different condition to the other two. And so access to the medicines via the PBS is very different. They relate to how you need to be diagnosed with ankylosing spondylitis. They relate to using anti-inflammatories rather than conventional DMARDs, because we know conventional DMARDs are not effective for the spinal part of ankylosing spondylitis, and the criteria are slightly different. And again, in ankylosing spondylitis, we might make a decision based on not just the symptoms of the inflammation in the spine or in other joints, but also on whether the patient has other related conditions like the eye disease, the uveitis, inflammatory bowel disease, and also psoriasis occurs in this setting as well. So there are a few different things that might cause us to choose a different one, but you can see the ones that we have available are very similar to psoriatic arthritis. The only one the ones that are not there are the anti-IL-23 blockers, which have not been shown to be particularly successful in ankylosing spondylitis. So just to briefly mention biosimilars, because I know this is part of what people wanted me to cover today. And really, I just think that there are some practical issues related to biosimilars which we need to consider, because I am very reassured by the continual demonstration that these drugs are very safe. They are very similar, as the name suggests. There's lots of what we call post-marketing surveillance now. So once the drugs come on the market, not only do we have the evidence that we had from the clinical trials or the clinical equivalent trials, but then we have a whole lot of information that has to be gathered when a drug is given approval to be utilized. There is a whole system of surveilling those drugs to make sure that they're not causing any problems. But practically, the problems that I find for people are in not knowing. And that's because these drugs can actually be substituted. So, for example, if you are receiving the originator drug called infliximab in hospital, it may be that your hospital or health service has purchased a particular biosimilar, and they will roll that biosimilar out across the health service. And so rather than receiving the original drug, the originator drug like infliximab, you might have a drug called Renflexis or Inflectra, and there's various drugs. Now, practically, when they're being given as an intravenous infusion, that's not so much of an issue. But when they're an injection, the reason it's an issue because they tend to come in a different pen or a different syringe. And that can be really different for patients when they are used to one pen or one syringe, and the biosimilar, whilst you're receiving a very similar drug, and we don't expect there to be an issue related to how well it works or otherwise, it can be a different pen. And that can be really tricky for people. So if your specialist ticks a little box saying substitution not permitted, if you decide that you would like to have the same drug every time, then a box can be ticked and you can receive whatever drug it is that you would like to continue to have. And then the other thing I think is really important is you can always discuss with your pharmacist when you go to fill your script what the medicine is and what you've been having. And you might have a biosimilar and go, oh, it's totally fine, no problem. It doesn't worry me which one I have. But keeping track of that is just helpful from a sort of a logistical point of view. And your rheumatologist and your pharmacist can always help you in this regard. So from a summary point of view, because I wanted to just give time to have some questions and things, I think it's just really important to consider that, these medicines are part of the treatment possibilities. They, for me, I think, have really revolutionized the way we can give treatment to some people, not everybody. But they certainly give us more options. So they give us a lot more opportunity to, particularly if particular medicines don't work or they partially work. You might have noticed that there's a trend now where we really want to be quite ruthless about how much inflammation we get rid of and how close we can get people to what we consider a remission, right? And that should be our target. We're trying to treat to a target these days with inflammatory arthritis, and that target should be that we can't find any inflammation. Now, in the real world, of course, that's not possible for everyone, or it's challenging because of other things like other medical conditions and a whole raft of other things, but that's what we're aiming for. So it's good to have all of these different drugs that block different things to have the opportunity to try different things. But they're often not required or not appropriate for some people, and we've just got to remember that that's the case. They are restricted, and so their access is restricted. And so your rheumatologist will be restricted based on those criteria. And not only do you need to fulfill those criteria, but you need to show a continuous response. So some of you will be familiar with having to see your rheumatologist every 6 months, have a blood test, have your joints examined, et cetera, for the purposes of continuing to fulfill the criteria. It's been a bit tricky in the past with the PBS for patients and for their specialists in terms of having to send off paperwork. Now we have some systems which are a little bit better in terms of an online system and otherwise. And now even better is that sometimes we can put a little code, a streamlined code on the scripts now, which is and just hand the script over to you, which is much better. But that's not for all parts of the PBS yet, but it's sort of getting there. So there's been some advances in the logistics, if you like, of accessing these medicines, but nevertheless, they remain in this special scheme. Just bear in mind that biosimilars and BDMARs are both used in Australia, and they're variable and dependent on the particular originator drug. There are a number of them, available now. I just think it's really so important, GP, and bearing in mind that decision might change over time. It may not be static, and that it's important really to have the conversations around that. Sometimes these drugs stop working. So we know, particularly with the biologic medicines, that the trickiness of these diseases and your immune system is that sometimes the immune system will start to mount an immune response against the drug, and that can actually cause the drug to lose its effect. So you can be really great on a particular medicine and then all of a sudden or over time lose how well that drug was working. And that's related to these diseases, which are very tricky. And the immune system can be quite evasive and can be problematic in another way for us. Lastly, just remember that, medicines are not everything. They are absolutely a crucial part of the management of inflammatory arthritis, but there's many other things to consider. And I would encourage you always to seek support and assistance. And Arthritis Queensland have on the website, lots of information. They also have a helpline, and they have lots of programs and groups and otherwise that can help you. So I really, really encourage you all to reach out for that help. So on that note, I'm happy to take some questions. Let me just see if I can bring the chat up here.
Helen, I might just stop the recording and we can go into questions.
Okay.